Joining me now is Dr. Ira RashBaum of the NYU Langone Rusk Rehabilitation Center. He's not only the chief of stroke rehabilitation, but he also helps patients who are suffering from chronic pain and musculoskeletal disorders. He also spent many important years working with Dr. John Sarno, who wrote several books on the topic of the mind's impact on the body. Dr. RashBaum is here to give us a little more medical insight on the mind, the body, and pain. Dr. RashBaum, thank you so much for joining us today on Bodnog Radio.
My pleasure. Thank you for having me.
I know that you've really had a really great opportunity to put a lot of insight not only into what you do, but especially this issue related to the mind's impact on body pain. But before we kind of get into more of that, what would you like to share with everyone about your background? I know you also deal with stroke recovery as well. Can you just talk a little bit about your background and how you got involved in just this side of the medical industry?
Yes. So I went to medical school not knowing exactly what I wanted to do with myself in terms of choosing a path. And then as my training ensued in medical school, I finally narrowed my choice down to the field of physical medicine and rehabilitation, sometimes called rehabilitation medicine or physiatry or physiatry.
Mm-hmm.
And I applied for residency programs out of medical school and was able to land a position at New York University Medical Center, at the time now New York University Langone Medical Center, in their Department of Physical Medicine and Rehabilitation at the Rusk Institute of Rehabilitation Medicine. So there I was doing my training in that field and trying to be exposed to all sorts of approaches and ideas in the field. And certainly in the field of physical medicine and rehabilitation, one of the most important areas is understanding pain, not just pain management per se, but actually understanding the roots of pain and trying to get a better understanding of what's behind this, and in any particular case of a patient with problems, to see what we could do to help them. So as my career evolved, I found that two areas of interest were in pain rehabilitation as well as in the area of stroke. So even to today, to this moment, I work in both fields. I'm the medical director of stroke rehabilitation at Rusk Rehabilitation, and also have this area of interest for many years in pain, and particularly in the work that mirrors that of Dr. John Sarno, who was a professor at the medical school and the medical center and pioneered a very unique approach in helping people with pain.
Yes, and he became very, very, very popular and well known for that research. And I know that you've had the privilege to work with him over 20 years, especially as it relates to that topic. And I know that a lot of that dealt with helping people understand how stress and other psychological factors can contribute to things like back pain. And a lot of that stemmed from research into what he called TMS. Can you talk a little bit about that and the psychological factors when it comes to pain?
Yes. In fact, if you were to search for TMS, you would most likely find something completely different, which is called transcranial magnetic stimulation. But this is a different TMS, as I'm sure you know. And the original term for TMS was tension myositis syndrome, because Dr. Sarno, back in the 60s and the 70s, he postulated that muscle was the main body tissue involved and presumed that there was some sort of an inflammatory process, ergo the term myositis. As time went on and there was a greater degree of understanding, he understood, partly with my help, that inflammation wasn't really playing much, if any, of a role in these pain syndromes, and also other body tissues such as nerve and tendon could also be involved. So the name then changed from tension myositis syndrome to tension myoneural syndrome, which involves muscle and nerve. So that was a necessary name change, not one made out of some other kind of reason. And what I'd like to let your listeners understand about Dr. Sarno is that he, in his own right, was a full professor at a very early stage of his career, was a favorite son, metaphorically speaking, of Dr. Howard Rusk, and was very well thought of nationally and internationally in all other areas, such as stroke rehabilitation, orthotics and prosthetics, and particularly outpatient musculoskeletal rehabilitation. So I know this may sound like a bit of a stretch, but I often think of Dr. Sarno like Picasso, where an artist who was able to master some of the traditional genres of his craft or his field, and then was able to sort of start his own area. And
Right.
one other point I wanted to make is that what I thought was one of the many things I thought that was so good and still is good about Dr. Sarno is he really went back to basics. He was made the director of all of Rusk outpatient musculoskeletal and all outpatient rehabilitation 51 years ago. And Dr. Sarno, as he describes in his book, figured, okay, I'm going to treat these pain conditions the traditional way. And he found that the results were very unpredictable. And he said, okay, something's not right. This is my speaking, not Dr. Sarno.
Right.
Someone has a pneumonia, you give them an antibiotic, their pneumonia resolves. He was treating these musculoskeletal pain syndromes, neurological pain syndromes in the traditional way, and there was no predictability. So he went back to basics. He went back to what I tell my students, my patients, my residents, the best medical test that was ever invented, the medical history. Even Dr. William Osler, considered by Medscape a few months ago the most important influential physician who's ever lived, used to say, listen to the patient. He's telling you, or she's telling you what's wrong with him or her.
Right.
And he realized decades ago that almost 9 out of 10 patients with these pain syndromes had some other medical condition that was thought to be due to stress. So then he said maybe that might apply here, and that was generally his conclusion in most situations.
It's interesting that you bring up antibiotics, because I know another thing that Dr. Sarno was involved in as well, as far as really researching this, was, and I think this kind of ties into what you were just saying, is sometimes the automatic thing is, oh, well, you got pain, take this pill. Part of what was inspiring to him to look at the impacts of things like stress is for that reason, not always, resorting automatically to pain meds or other things. And in this day and age, people are already beginning to recognize that sort of thing when it comes to not automatically prescribing an antibiotic for a virus or, typical problems associated with antibiotics. His research is also rooted in a means of making people less dependent, not only doctors, but also people who suffer from pain, to not always think, okay, well, I'm hurting, so obviously the automatic thing that I can do to fix it is take a pill. Whereas if you have some behavioral changes or some stress behavior changes that you can make, that might be even more effective in some cases.
Exactly right. One way of looking at it is that in a legitimate way, this approach can help patients take an active role in helping themselves not just get a little bit better, but often completely better, versus taking a passive role. And yes, you may have to actively take a pill and put it into your mouth yourself, not have a nurse or someone else do it for you.
Right.
However, it's still some degree of passivity to it. But also, I just want to add, particularly for your listeners, is that one of the common misconceptions about my practice, about our approach, is that we're somehow against pain medication. And that is certainly, nothing is farther from the truth than that.
Sure.
Sometimes I'll tell patients in the office or in the lecture halls that we're not in the Wild West in the 19th century, and you have to go outside the saloon and sort of bite a bullet, as
Right.
where the expression comes from.
Yeah.
Certainly, if you need the pain medication, at least in the short term, you take it. In fact, when I first started learning with Dr. Sarno in the 1990s, the early 1990s, I was in a way surprised, even after having read his books, how commonly he would prescribe even strong pain medications. And I said, but wait a second, Dr. Sarno, what are you doing with that? He said, in the short term, sometimes in the intermediate term, patients may need this until their symptoms will get better. And the other concept about that is, other than when I tell patients, if you're going to be taking even what may seem to be innocuous pain medications like acetaminophen, Tylenol, or ibuprofen, Advil, what have you, say, make sure you're following up with your primary care doctor, because even not just opioids, but some of these over-the-counter medications, they can have side effects, and make sure that you're touching in with your primary care doctor to make sure that they're on top of things, make sure they may need to take some blood tests or stool tests just to play it safe. But the other point I wanted to make is that even patients who were coming to see us with very significant intensity of pain and chronicity of pain, who were often on strong pain medications for long periods of time, as their symptoms were getting better and often resolving, that they found themselves, rather than having to wean off these pain medications in a very prolonged weaning way, not uncommonly, they would just sort of self-discontinue these medications. They would say they just, A, don't need them anymore, and B, they didn't feel good when they were on them.
Yeah. Well, let's take a deeper look into how the mind can generate pain in the body. Can you talk a little bit about how you and Dr. Sarno have explained both how the conscious and unconscious mind is involved when it comes to feeling pain?
Absolutely. In fact, what I'd like to do is let's subdivide this into how do we think the symptoms are coming on physiologically,
Okay.
or what you would call physically, and how we feel the psychodynamics are going on in our mind. So let's touch base first on the physiology.
Okay.
Is we think that the pain is due to a very mild ischemia. Ischemia means decreased oxygen concentration or flow. Now remember, I'm a stroke doctor, so I deal with patients who have significant decreased blood flow to a part of their brain. This
Yes.
is not what we're talking about here. I teach patients all the time that the decreased blood flow to muscle or nerve is not enough to cause any damage to these muscle cells or nerve cells, but just enough to cause symptoms. Look at it this way. If the total ideal oxygen concentration to some muscle or nerve or tendon is 100%, this may be 98%, not causing cellular damage, but enough to cause pain. And we think that the part of our body system that makes this all happen is called our autonomic nervous system, or what Norm Crosby, the old comedian, would have called the automatic nervous system, where it's the part of our neurological system that does automatic things that we generally don't have to think about, such as digestion, respiration, and the like. In TMS, the way we see it is that our brain is just kind of turning down the thermostat just slightly to one or more body tissues or regions to the body in order to cause these very attention-grabbing symptoms. That's the physiology behind this. What about the mind? Now we sort of borrow a lot from that guy named Freud, number 5 on the list from Medscape just several months ago as the most influential physicians of all time.
Yeah.
He talked about, of course, the conscious mind, the unconscious mind, and for our patients and for our teaching in our practice, in our program, we call it the subconscious. So if we were looking at this like in a geological way, the top layer would be called the conscious mind, middle layer we'd call the subconscious mind, and down at the bottom we'd call the unconscious mind. When I was 10 or 15 or even 18 years old, if someone told me that the majority of our brain activity is below the level of consciousness, I would have thought that that was malarkey.
Mm-hmm.
However, listen to all sorts of people. They have now verified that brain activity is, the vast majority of it is below the level of consciousness. It just seems to be the way it is. But to finish the concept out and the thought out for your listeners is we think of the mind as what I like to call an emotional manufacturing plant or an emotional factory. There's a very important transformational idea that whether you realize it or not, that on a consistent basis, it seems like our mind is creating emotions. And believe it or not, it seems that the vast majority of the emotions that we manufacture, we create, we do not feel, meaning that those emotions seem to stay in the unconscious part of our mind and don't bubble up to the surface, shall we say, all the way up to the conscious mind or the consciousness. Some people would say that's ridiculous. Well, I would have thought that 40 years ago. That doesn't seem to be the case. What we think is the psychology behind TMS is that emotions such as anger, rage, sadness, fear, guilt, shame, loss of vulnerability, any of these emotions, and they can, believe it or not, we've only learned this in the last 3 or 4 years, can even be, shall we say, nicer emotions or less thought to be threatening emotions such as happiness, love, joy, that when these emotions enter unconscious, at least some of them try to an appreciable degree, try to go all the way up to consciousness, apparently one part of our mind doesn't seem to like that. It seems to be afraid that if the intensity of some of these deeper repressed emotions make it all the way up to consciousness, something bad's going to happen. We're going to explode. We're going to do something that's going to make us feel ashamed, all sorts of things. And those emotions, by and large, will stay repressed. But the brain, still somehow afraid that, shall we say, the psychological levee is going to break, will create what we see as a physical distraction. And believe it or not, we think that that is in the form of physical symptoms such as pain. And that is what we think is the psychology, by and large, behind TMS.
There's obviously a lot that happens when you really start talking about some of those that are already intense emotion, psychological elements, like you were saying, like fear and stress, because we already know those sort of things can make you sweat, make your heart rate or make your blood pressure go up. So, I mean, it's not all, to me, it just doesn't seem all that much more of a stretch to also be able to acknowledge that it can be doing other things to you, like causing pain as well.
These emotions seem to be coming from pressures, and these pressures are in 2 flavors. Again, I'm a stroke doctor.
Yeah.
When I talk about secondary stroke prevention, we talk about internal risk factors, sort of external risk factors. I like that same model with TMS. Believe it or not, we think that the internal risk factors to the propensity to develop TMS are personality characteristics, such as being a highly responsible, conscientious person, sometimes even a perfectionist, and or being what we call a nice person, a people pleaser, a goodist. Not a doormat, but someone who may have a general tendency to try to be nice. And someone may be thinking, one of you or more of your listeners, what does that have to do with anything? When we look at it in terms of a psychological way, those tendencies to be nice, to be responsible, may be perceived by this other part of our mind. Freud kind of called it the id. Dr. Sarno called it the child primitive or the inner child. Doesn't seem to like that all this time. The other thought and the other concept to make is that you may think that if you saw or spent a day with me in the office, that you'd be looking at a whole bunch of stressed out, anxious-looking people who are sort of pacing the hall and swearing under their breath and biting their fingernails and sweating profusively. And I have to tell you that that is far less than 5% of my patients. So you may say, or the skeptics may be thinking, well, this whole way of looking at this is completely fallacious. Actually, not at all. And the point I'm making is that that my patients are certainly having these stresses. And the key phrase is our patients tend to internalize these stresses very, very well.
We will continue our discussion with Dr. RashBaum here in just a few minutes, and we'll dive even deeper into the patient side of things. We'll talk a little bit about how Dr. RashBaum goes about determining whether the mind is really impacting pain and whether it's a situation where TMS is involved. We'll also discuss the patient's response to finding out that this might be happening and really what steps they should take if indeed the mind is playing a role in the pain that they're experiencing. That's coming up next on Bodnog Radio. On the next, Who Wants to Be a Really Rich Person?
All right, Bobby, here is your next question. Which of these things does not cause back pain? Anxiety, obesity, bad posture, singing in the shower?
Well, I'm pretty anxiety-ridden right now, and I'm feeling it in my back.
Okay.
Posture, I think, would. Obesity, I think, would. But if I'm singing in the shower and I do a little Michael Jackson move at the same time, that could throw my back out. I want to do a 50-50.
All right, the question is, which of these things doesn't cause back pain? Anxiety, obesity, bad posture, or singing in the shower? We'll remove anxiety and obesity. Those cause back pain. Between bad posture and singing in the shower, which does not cause back pain?
Oh, this is so hard. I'm gonna go with singing in the shower, bad posture. I'm gonna go with phoning a friend.
Okay, who would you like to call?
I'd like to call my buddy from college, Mitch.
Okay, let's get Mitch on the phone.
Hello.
Mitch, which one of these doesn't cause back pain?
Doesn't cause it?
Right, tell me what doesn't cause back pain, bad posture or singing in the shower.
Can you give me the choices again?
Which of these doesn't cause back pain, bad posture or singing in the shower?
Oh, man, this is tough.
I know!
Well, it's so tough because I tweaked my back singing in the shower yesterday. I was belting out I Feel Good and did some James Brown moves and slipped.
I hear ya.
Posture, shower. Posture, shower. I just don't know.
Find out what happens on the next Who Wants to Be a Really Rich Person? Welcome back as we continue our discussion about the potential for the mind to help contribute to body pain. We're here talking with Dr. Ira RashBaum. What is your process, and like maybe even process of elimination, where you start to think that someone's pain, whether it be in their back, in their knees or arms or wrists, could be stemming from something more psychological instead of, maybe some of the other typical reasons why people might be suffering from pain?
Absolutely. I tell patients when I see a patient in the office, despite what I know about TMS and my years of experience in evaluating and managing it, I presume that every patient who comes in the office does not have TMS. I guess that's called the null hypothesis.
Yeah.
And then if I can logically and responsibly, I try to disprove that. Sometimes I cannot. So, of course, someone comes into my office with a broken ankle or a broken hip. You don't need to be a physician or a healthcare provider to realize that that's not TMS.
Yeah, that hurts.
That's not usually the situation. Exactly. I broke my ankle about 5 years ago, and it was a pretty unpleasant 4 to 6 weeks, I must tell you. However, hearing things about history, for example, if someone comes in with, let's say, psoriatic arthritis or rheumatoid arthritis or chemotherapy-induced nerve damage from, let's say, needing treatment for cancer, of course, I would say virtually, if not exactly 100% of those cases, those are not TMS situations. But I think what your listeners are also interested in is, what about these things that we hear about herniated discs and spinal stenosis and this, that, and the other thing? Well, yes, in certain situations, when I do a history and a physical examination of a patient who has had some studies such as a magnetic resonance imaging or MRI study that may reveal some of these structural observations, in some situations, the minority in my case, I do think TMS is not the right diagnosis. Let's say if they have certain neurological abnormalities on their physical examination. Real quickly, if someone has, let's say, an L5S1 large herniated disc on the right side, and on physical examination, they have an absent right ankle reflex. They have very weak muscles that turn their foot and ankle down, and if they have decreased sensation on the outside of their foot, I would say in virtually all situations, that probably is not TMS. So we do a meticulous physical examination, particularly neurologically, a very careful history, and we look to see with any diagnostic studies if something else is going on, because nobody wins if we're making a diagnosis that's not accurate.
Right.
So that's first and foremost. But let me also add that if you start to look at people like orthopedic spine surgeons, neurosurgical spine surgeons, neurologists, all sorts of other practitioners, there's an increasing understanding, particularly in the last 10 years, that so many of these observable structural changes on CAT scans, MRIs, may be there even in people who do not have any symptoms. So what I tell patients very often is that at times, at least, the healthcare providers, the patients, do what they call a diagnostic rush to judgment. The person is having symptoms, a scan is obtained, the scan doesn't look pristine, and it becomes like Perry Mason, an open and shut case, and sometimes that's not necessarily right. I have to remind people as they get into their 30s, 40s, 50s, and beyond that I often say it's abnormal for a person to have a normal MRI, regardless of how they feel. So we've got to keep that in mind.
Once you've identified that the root cause for a pain might be more psychological, what do you tell that patient? What's involved in improving their situation? Is it as simple as just getting them to adopt, some new habits or lifestyle changes that reduce stress, or perhaps mental outlook or mental approach to their daily life in a way that would perhaps help the situation a little more?
Absolutely. Great question. So let's take you through an office visit.
Okay.
A patient is in the office with me, and after all is said and done with a history, a physical examination, review of any diagnostic studies, it's my diagnostic impression that this person has TMS, or tension myoneural syndrome. I say, okay, this is what I think you have. So one of my phrases over the years that I tell patients is this, that you get a B for belief. And remember, in school, a B is a very good grade.
Mm-hmm.
So a B is believing the diagnosis, but you get an A if you accept the diagnosis. So I say, what's the difference between accepting and believing it? Well, you can believe in anything. Belief does not have to include any sort of logic to it. It's just a belief. My view, at least in the world of TMS, is that acceptance is belief plus this kind of makes sense to me. I don't want my patients to leave the office saying something isn't adding up here. And that's why I tell them, even I'm a skeptical person, I tell them, I'm doing mind-body medicine, but I was a major in chemistry in college. I was an intern in general surgery. So you'd think I'd be the last guy on the planet doing this kind of work. And I tell them one of the reasons I do this work because it's logical to me. And if I don't think everything adds up properly, you don't get a TMS diagnosis, and we need to steer you in another direction.
Yeah.
So the first step is to say, okay, do I at least believe this diagnosis and hopefully accept it with some, it makes senseness to it? That's the first step to this, because I also look at another weird metaphor. I think of like these old-fashioned balance scales where you had, even when I was a chemistry major, before we had electronic scales, you used to have to sort of balance things on both sides of this thing.
Yeah.
And I realize I'm one doctor, and sometimes I've seen 2, 5, 10, 20 doctors, and they're telling them something else. And I have to respect that and say, I get this. This is not necessarily going to be so easy for you. So I'm telling you that I'm not trying to be disparaging to anybody, but this is my diagnosis. I think it's logical. It makes sense. And I have to respect the reality that many patients have had so many other doctors on the other side of the balance scale who are telling them the world is flat when I'm telling them the world is round. The next thing is I try to educate them. Now, we can educate patients in 2 ways. Certainly, Dr. Sarno has written multiple books on this. So there's lots of good information. And the most recent book was published, I remember the date, April 1st, 2006, 10 years and about 4 months ago. And for people who only want to use my practice as a consultation service, sort of a one and done, they can have a combination of my confirming a diagnosis if I have, plus going back to the book and reading it and sort of using education as medicine. However, as my predecessor did, Dr. Sarno, I also provide what I call therapeutic education in the form of treatment lectures, where I basically, figuratively, not literally, of course, I throw the kitchen sink at them. I teach them everything I know about this in 2 lectures that last about 75 minutes each. So a total lecture series of 2.5 hours. That's a lot of time. I can't do that in 5 minutes at the end of an office visit.
Sure.
And I go over all sorts of data. In fact, I tell my patients is that The Divided Mind, Dr. Sarno's most recent book, 10 years ago published, that I include lots of information in the lectures that have been known to us after 2006. All sorts of papers that have come out in major journals like the New England Journal of Medicine, Spine, JAMA, all sorts of publications like that, that may not necessarily be talking about all sorts of doctors completely embracing TMS as a valid diagnosis.
Yeah.
However, they often talk about the sort of, how we say, something is rotten in the state of Denmarkness of looking at this in the other way. Or another way, I'll say, if you really understand the medical literature and the surgical literature by and large out there, I often see treating these pain syndromes in the traditional way as not very logical. It becomes a combination of that, diagnostic confirmation as well as therapeutic education.
You're talking about the belief element. How accepting do you generally see patients are, if they are in some pain and perhaps one of the reasons why we sometimes might take a quick Advil or something is because we want that immediate relief. But if they know that this is something that might involve a couple of lectures and, some behavioral patterns, some things that are going to take a few days. How accepting have patients been when you have identified that as possibly part of their issue and tell them that that's what they need to do in order to get better? And can you think of a situation where you've seen it work out great for someone that you'd like to share?
Sure. Well, most of the patients who seek me out have often read about Dr. Sarno's work. They may have seen about it on the web or this, that, and the other thing. So you get a fairly accepting patient population coming to me. That isn't to say that if you talk about these ideas on a general basis among all walks of life, would most people out there necessarily buy into this basic way of looking at things? Well, I'm not so sure that they would. So I'm not trying to, I may live in a sort of a TMS ivory tower to a certain degree. However, I'd like to think that as time goes on, that people will be more accepting of this. And even as Dr. Sarno, I think, used to say, that patients tend to be more accepting of these ideas than the medical profession itself. As far as the time frame is, yes, this is for people who are looking for doing this more conclusively, but over the longer haul.
Yeah.
Rehabilitation medicine, Dr. Rusk, the Rusk Institute, all sorts of rehab centers around the country and world, that's preaching to the choir. We tend to, in rehabilitation medicine, not look for results in hours or minutes or days. It's often weeks or months, and that's the norm. So I don't promise patients, like the old song goes, a rose garden.
Right.
Most often, this is going to take weeks or months to get conclusively better. Can it get better in the forms of days or weeks? Absolutely. And I get feedback from patients not uncommonly to that effect. But yes, medication in the short term and sometimes the intermediate term needs to be part of that whole solution. Adjunctive medication while they're working on this through the treatment lectures. I give them an 8-page study guide for people who come to the treatment lectures. They do some self-work, often some journaling, and that often is helpful. Let's just touch on this, though, for a moment. Let's say we have a good patient, hopefully a good doctor, myself, a proper diagnosis made, proper treatment administered, results aren't great. Then what do we do? Well, we have some options. If the patient and or the doctor is somehow shaky or confused or concerned about the validity of the previously made TMS diagnosis, I tell people not to frighten them, but to reassure them, I don't have blinders on. If this isn't getting better, let's go back to square one or to square 1.5 or 2. Is the diagnosis correct? Some patients will, for whatever reasons, refuse to get an MRI scan. If that's something, and I say, well, maybe we need to think about that just to play it safe. Things along those lines. Most of the time that's not necessary, but occasionally it needs to be done. What else can we do? I run proactive support groups called small group meetings for patients who've either come through the program and they're not appreciably better, say 6, 8, 12 weeks after we started, or for people who are doing well and they have had a recurrence of symptoms months or years down the road. And I invite people to no more than 3 of those in the course of a year, and those are often very helpful. And the other thing we do is for people who are not getting better, it should come as no surprises, we will recommend that they start working not for decades and for millennia, but often for weeks or months with a psychologist. A psychologist, are you saying I'm crazy? No. We're saying that if ultimately TMS is the correct diagnosis and there are some psychological forces at play, a psychologist can do what I can do. A psychologist could do what Dr. Sarno can do, and it's basically 2 things. One, no matter how smart the patient is, even if the patient is a Rhodes Scholar, a patient sometimes may not be aware of a stressor. They may have sort of a symptoma or a blind spot, metaphorically speaking. Sometimes the psychologist is very good at pointing that out for them. But I think what I'll call the secret sauce in this in terms of psychology is, and this is what sold a skeptical chemistry major and surgical intern on this work, is for people who do work with psychologists who are start to be able to tolerate some of the stronger emotions inside of them and even sometimes feel these stronger emotions. What has been my experience for 25 years is symptoms invariably decrease and often resolve. So what that means is people who do work with psychologists can, as they say, be more in touch with your feelings. Magic seems to happen, and it's not magic. As the people are more in touch with their strong feelings that they were repressing previously, the need for the brain to create the physical symptoms vanishes.
Well, finally, my last question is, after, if we have some people out there listening that have been dealing with perhaps an ongoing issue with pain, and they've tried a couple of things and maybe not working as well as they want, and they listen to what you're saying and they start to think, maybe this is my issue. Maybe this is what could be contributing to my situation. What can they do to maybe step back and really consider, based on their history, if this is a problem, and then what they can do from that point on to really start looking into it as a possible symptom of their pains?
This is a very important question and an excellent question, and I'll explain why. Because until this matrix and model of looking at the etiology of symptoms and the resolution of symptoms is more widely accepted, patients are defined because it's not as if they can walk down to any street corner or any local community hospital and often find a whole series of healthcare providers who are going to buy into this.
Yeah.
So that may be a bit of a barrier. On the other hand, we do not want our patients to be their own physicians, even if they are a physician. The older expression, you shouldn't be your own physician for a variety of reasons.
Yeah.
So be that as it may, what I tell patients, especially because I'm very fortunate, patients will call into my office. I do this for up to 5 minutes complimentarily for all over the country, is I'll say, at least let's see what the physicians who have been caring for you, what do they think? Mm-hmm. Because is there a valid alternative diagnosis that's not TMS that has been clearly established? Rheumatoid arthritis, or psoriatic arthritis, chemotherapy-induced polyneuropathy, all sorts of other things, an occult fracture. If those things have conclusively ruled out, then what I tell people to do is this. Ideally have TMS diagnosed by a physician, and sadly there aren't a lot of physicians around who diagnose this. There are a handful throughout the United States of America. That's how unfortunate the numbers are. It's not dozens or hundreds. So if they want to be able to reach out to physicians such as myself or to other colleagues around the country to see if possible they can say, yes, this is what I think you have, that could be very empowering. What I did not say earlier in the talk or in our conversation is that without sounding self-serving, my psychology colleagues practically have begged me to say this to patients, and it's not so profound, is that if you're in sort of wandering in the diagnostic wilderness and someone who has experience diagnosing TMS says this is what you've got, that in itself has very positive therapeutic overtones. So that's very important to keep in mind too. So simply stated, if someone is in a position and is fortunate enough to have a physician with TMS experience able to make that diagnosis, that's the optimal. If not, at least if they have gone to a physician or a series of physicians and other kind of serious conditions have been properly ruled out, then probably the next best thing to do is to get one of Dr. Sarno's books, even if it's out of the library, not asking people to buy it, and in a sense, see if having greater knowledge and insight through the book, especially The Divided Mind, could be healing back pain, mind-body prescription. If that's not enough to help their symptoms get appreciably better, then we say try to reach out to a local psychologist, but not just any psychologist. And I'm not trying to antagonize anybody, but our preference is psychologists who have analytical training. I guess any psychology is fine, including cognitive behavioral work, and sometimes in a psychological experience, cognitive behavioral techniques need to be done, but our preference is to work with a psychologist who has analytical training, who can help a person, Freudianly speaking, explore their unconscious with them to try to help them be more in touch with their feelings to help these symptoms go away.
Awesome. Great. Well, between the books and the options that they have, perhaps locally and around the country, and then, having the options of psychologists as well, at least people know that there are resources and options out there for them. And thanks to our talk today, they have a great understanding of at least something else that they perhaps didn't even know might even be contributing to their pain. So I really appreciate you coming on and joining us today to really give us some good insight on the factors involved here and things that people really need to think about when it comes to the pain they might be suffering. So it's very valuable information. Thank you, Dr. RashBaum, for being here with us today and for your time today, sir.
It's been a pleasure. You've been a great interviewer, and thank you very, very much.